Thank you for staying with us. The National Association of Resident Doctors have begun a 5-day warning strike following the failure of doctors to meet the federal government to meet their demands. Some of its demands include an immediate increment of their gross salaries and immediate withdrawal of the bill seeking to compel medical and dental graduates to serve compulsorily in Nigeria for 5 years before getting full licenses to practice. Immediate domestication of the Medical Residency Training Act, amongst others. Although the federal government threatened to replace them with ad hoc staff and implement the no work, no pay policy, major activities across most hospitals in the country were grounded as many doctors from the association refused to work. A tour around the National Hospital in Abuja shows full compliance with the strike, making patients' waiting time increase by more than 50%. Health correspondent Kemi Balogun has details.
Out of the 5-day warning strike by resident doctors, activities here at the National Hospital appear normal at first glance, but a closer look tells a different story. Patients at the center of it all are at the receiving end of longer queues and longer waiting time. Pascal is one out of those who had no idea there was a strike in play when he got into the premises.
I was shocked when I went into the emergency accident whatever department, and shockingly the place was jammed, locked, and it's sudden, because if somebody has an accident suddenly and then rushes this place probably to save a life, what happens?
We are told that we can't get any doctor, that the doctor around have seen enough, that we should go and come back another day. They wanted to take only 30 persons.
The hospital management admits there is a gap created due to the strike, but it has been proactive and set up measures to ensure that services continue for patients. And it is urging for a quick resolution to the demands of the doctors.
We might likely discharge some patients, because of the resident doctors' strike. But not that we will not accept patients, in terms of emergency, but we definitely reduce the rate of admission.
The Nigerian Association of Resident Doctors had issued a 2-week ultimatum to the government to meet its demands before it resolved to down tools for the next 5 days.
We've had situations where residents have collapsed at the emergency unit because they were stressed, because they were on calls. And the management of hospital, National Hospital per se, have tried to reach out to government that they need to replace people that have left.
Some other issues they want resolved are a 200% increase in the consolidated medical salary structure of the current gross salary for doctors, an immediate suspension of a bill seeking to ban doctors from migrating until after 5 years of practice, and also an implementation of the commerce payment structure by states yet to do so. Within the last 10 years, resident doctors have down-tooled more than 150 times, including during the pandemic. Now, these strikes continue to take a toll on the effective service delivery for patients. Kemi Balogun, TVC News, Abuja.
Well, joining us in the studio to discuss more on this is public health consultant Dr. Tui Mebawadu. Good morning. Thank you for joining us.
Good morning. Good to see you. Yeah.
And via Zoom, from the United States of America is U.S.-based medical doctor and convener, Social Rehabilitation, Grace and Support Initiative, Dr. Maridoti Oludari. Good morning. Thank you for joining us.
Good morning, Veronica. Thanks for having me.
Right. If you look at the papers this morning, one of the papers, that's the Daily Trust, is saying that the federal government is set to replace striking doctors with ad hoc staff, and that they are looking to implement the no work, no pay policy. What do you make of government's stance with regards to the demands of the resident doctors?
Well, thanks for that question. My first observation would be that there is always an argument that comes up whenever doctors want to go on strike, and that's the Hippocratic Oath. And so I want to get ahead of it because I think it's like an Hippocratic blackmail on doctors. Hippocratic Oath says that doctors should first do no harm. It does not compel them to go to work. And the utterances of the Minister of Labour, I think, has been quite regrettable, even think about the ASU strike where he walked out of the negotiation and the statement saying the doctors have entitlement syndromes, what doctors are talking about is really valid. I was having the conversation with one of my colleagues a few hours ago, who is now a senior resident, about to be a consultant, and his salary right now, despite having gone up in numbers by threefolds, is worth about half of what he used to earn as a house officer. So if the doctors are saying they want a salary increase, it is a valid concern. It is something that we need to sit down with them and negotiate with them. Also, in terms of like the medical residency training fund that they're asking about also, the exams that they have to take, they are super expensive, and the federal government has agreed to give them this money. So why can't they stick to that agreement? They paid it last year, they've not paid this year. And the 5-year ban also that they want to withdraw, it is only going to harm the doctors that want to stay. It's Nigerian medical license that they are trying to deprive Nigerian doctors, not Nigerian doctors that want to work in the UK. Nigerian doctors that want to work elsewhere don't need the Nigerian medical license. They will go and get a license where they want to work. So these things are very valid and very sane demands that they are making from the federal government. However, we can talk about the problems right now, which is what the bone of contention, but this will still not solve the eternal rotating strike problem that that occurs in the federal government system, because should the federal government, or when the federal government grants the demands of the doctors, then other health workers will also come and come up with a strike, and then there will be a paralysis in the system again. So there's a need for a rethinking of the way the healthcare financing goes in Nigeria, essentially. That is one thing that I think would be a more lasting solution. However, when it comes to the demand of the resident doctors, this, if you want to triage the situation, this is the acute problem. They need to think about it. They might not, agree to the 200% demand that they're having, but at least let an adult be in the negotiation with these doctors and give them a plan and give them a way forward. There is supposed to be a one-to-one replacement of doctors. Everybody knows about the Jackpot syndrome, but the doctors are not being replaced, and there are doctors that are looking for employment. So these are salient matters that the resident doctors are fighting for, and I believe this strike is for the benefit of the people, because what is the essence of you going to a hospital in an emergency situation, or you meet a doctor who is spent, who cannot even focus and give you the right, quality healthcare and attention that you need? It is first do no harm. So if a doctor is stressed out and is attending to an emergency situation that needs his full attention, it cannot be at optimal performance at that point in time. So the doctor is trying to hold on to its Hippocratic oath of first doing no harm, because if I'm tired, I might want to write 200 milligram and I write 200 grams. It is a fault of me, but it's not a fault of my own making. I was overworked. So we need to listen and get the next administration, definitely, thank God it's a warning strike. The next administration definitely needs to put an adult in the room who will have this conversation, stretch out this plan. This issue of doctors running around and even the 5-year bill that they're trying to pass. There was a health report in 2007 that predicted this thing when they started with the indexing in terms of the admission of medical students into schools. So these doctors, the myriad of problems they are complaining about, they are very, very valid, and they are seeking to find the lasting solution to the problems that they faced perennially. And I believe that, we need to solve them and listen to what they're talking about.
All right, Dr. Mibaunji, the call for the request for 200% increase in the consolidated medical salary structure, of course, one would say is very germane, because if you look at the standards of medical practice around the world, especially if you bring it down here, what the medical doctors face on a daily basis and the working condition, one would say that's not even enough. But let's look at the realities on the ground right now. How feasible would that be when the request for 200% increase in the consolidated medical salary structure?
Thank you, Mike. Essentially, I want to separate some key issues in this ongoing strike. The 4 demands are germane, no doubt. You can't take it away. Under this regime, we've seen the longest strike, especially from ASU and and National Association of Resident Doctors. These are intertwined organizations. If you combine both, you've seen more than 600 days of strike. You know, that's close to 4 years of strike under this regime. You know, so it's quite challenging. That's one. Secondly, the key thing the demand that makes it quite challenging is the fact that they're saying immediate and urgent before May 29th. Note that immediate urgent request, replace all the people that are leaving, give us clinical staff, this by 200%, and then increase what's it called, health budget by 15%. That can't happen before May 29th. Yes, those requests are germane. But the timing must be actually, you know, because again, when you are doing things, you have to actually look at the environment and what is possible. It is good, for instance, for us to lay those things before the incoming government, because you know how Nigerian government runs. The new one will deny, you know, knowledge of the previous one, and they say they are a new person. Then secondly, you've seen the worst response from government as represented by the Minister of Labour. How do I mean? Okay, you have 2 weeks where this guy had told you that, listen, we're going to go on a warning strike if these things are not met. At least, at that point, you don't neglect people. You come out and address the press. Tell them that, listen, the process of recruiting new doctors is going to take some time. We're going to place advert, do this, and then we can't do it before the time goes by. What we're going to do is that we're going to set the thing in motion and hand over to the people that are coming as a handover note for them to continue. You must be able to engage them. You don't just throw them away and say, what are they going to do? Because you are leaving. So, I mean, the response is very poor. Of course, the timing of the request is also an issue as it is. So, with this, and you look at the whole of the nation, dwindling fortune, everything, and then with maybe about 30,000 doctors treating about 200 million people, it's not it at all. And you look at it again, you know, it's just like supply-demand thing. You are not training. You know, you are not having, the labor minister says he's going to find ad-hoc staff. Where is he going to come here to pick staff? People just talk. Are you going to go on the street to pick staff to come and do health work? Now, I think there are fundamental issues that should change the whole of this dynamics, because, tell you what, Mike, we are not going to go over this. This thing will continue as long as we're having shortage of those doctors, as long as the condition of service is that bad, as long as the service, salary is that poor. We're going to have all this. I tell you, in the past 1 week, I lost 2 people. One even went to a public hospital and they said there's no space. I said, give phone to any doctors there. They refused to pick the phone. And the 33-year-old boy died. Another good friend, you know, like a cousin of mine, just fell down and died at the age of 61 or 62. He just collapsed in the night and died. So we are feeling it. If they are not feeling it, if they can travel abroad and get treatment, we can travel. We're feeling it. So, and they should have that compassion. If you cannot meet them fully, meet them halfway. Engage them, talk to them. And I see all sorts of excuses coming that enemy is with us, we're with enemy. No. You see, they should understand how National Association of Resident Doctors work. It is the striking arm of enemy. They are the one who is going to push and say that this is the thing we want. If enemy needs to fight now, they have to go to National Association of Resident Doctors and say, we need to fight, I beg, okay, strike for us. So you have to really know the role they are playing and engage them appropriately. If all these, if all politicians and a lot of people can take a lot of money, unnecessary money from the system, what is life without health? Yeah. What is remaining if you are not healthy? So I don't know. I don't know why we're just like, because we can still afford to go abroad and get treatment. And there's always a tired repeat that, you know, Nigerian doctors, their training is being subsidized. What sort of lie is that? Subsidized in what way? Okay? All graduates in Nigerian universities have reduced tuition. That is what you always pay. Books, items, everything, accommodation, you pay for it. And then Nigeria is not the cheapest country when it comes to health care. If you go and Google the cheapest place to train doctor, you won't see Nigeria there. So what are they telling us essentially? Cuba, you know, is there. It's virtually free. I studied and had a postgraduate degree in Sweden. And lo and behold, I didn't pay a dime except my maintenance. So people should honestly engage us intelligently. They shouldn't just manage and try to bamboozle anybody. So government response is very, very poor. But I also mentioned that the timing of the strike and the request tied to before May 29 is not feasible. It's not feasible.
All right. Olutare, let me come back to you now because of this matter of engagement. How best the government can engage, talking about the incoming administration now, as this is winding down, how best they can engage with associations like this to get the best out of them, and so that we do not have this reoccurring strike that we have witnessed in this administration.
The most important thing is, first off, you have to listen to them. You have to negotiate with them. Their concerns are valid. You first need to reinforce that. Let them know, I agree with you, but we are now looking for a way to solve it. The most important thing is healthcare financing. We need to rethink and rework it, like where the plan of the new incoming administration in terms of getting an healthcare national health insurance scheme where everybody pays into. It is very germane to these problems. That is how we can get the equipment that we need to deliver the required healthcare services. But there's one advantage that Nigeria has when it comes to health insurance. Health insurance, simply put, is the young and elderly subsidizing the old and weak. But the Nigerian population demographic distribution has a very high population of young people whom, if empowered economically, can pay into that purse, and then we have the money to fund residency, to fund infrastructural development, to fund, all these sweet programs that the doctors need, and we will not have shortage of this. And then also there's a need to reform, the whole system. I don't understand why we have federal government hospitals and then state government hospitals and all. In most places, federal government, state government, local government fund all hospitals. There's a certain percentage of, as a matter of fact, the state government and local government in the United States, for example, they dedicate more funds from their budget to the hospitals in their localities, as opposed to the one that we operate right now, where we give like some subvention to federal hospital, and then those hospitals now from there pay salaries and decide how they want to work things out. These are things that we need to retool. These are things these are the plans that you can put in front of the resident doctors. That we have a 5-year plan. Okay, you want us to work on your salary. We'll work on your salary, but aside working on your salary, we'll work on the economy too, because this exchange rate does not make any sense. Like I said earlier, a friend of mine whose salary in naira has tripled, but that salary has gone down by half in dollars. If you come, it doesn't make any sense. It worsens the hardship on the doctors, and then try to also go back to the drawing board and improve the recruitment. There's always going to be an attrition, but we need to make sure that the inflow of doctors from the universities can, cancel out that attrition rate. That is very essential, because we have started this whole indexing since 2007 or thereabout, whereby we've reduced the number of doctors that we are enrolling, so that we can, because healthcare is a labor-intensive service. We need doctors to be there. If you want to manage a neonatal, a preterm born, you need one nurse to be dedicated to one preterm, so that you can give them 100% attention, one nurse for a shift. So we need to increase all those numbers. A part of what we lack in desired resources, we need to make up for in required innovation and thinking. We need to think out of the box. There's no panacea for this problem. There's no one pill that will fix it all. Go to the United States, go to the United Kingdom, go to Canada, go to Cuba, go everywhere. There are problems in the health sector. So we should be able to just get from this space of nowhere to where we want to be. And like I said earlier, once the federal government agrees to the plan of the doctors, I can bet you other health workers will start strike again. And this will also collapse the problem. And this is also based on the fact of the structure that we are operating right now. I think the federal government has beaten up more than it can chew. So it needs to start regurgitating and retooling and restructuring even the health sector. It is very essential. It is like a house of cards that will easily fall on itself. But when you restructure it into manageable units, where we have health operation systems, whereby we can even pull nurses into more important role in delivery of rural services. Out here, like in the United States, they have nurse practitioners who go after their nursing education to train for a few, like 2 years, and then they can practice and, treat, let's say, malaria. There's no need why you need doctors to be treating malaria, typhoid, that which is essentially what a lot of Nigerian doctors do. We can pull those ones, train those nurses, put them in the rural areas, put the doctors into the residency program, and train them, give them good jobs, help get the financing up, get the economy up so that people can pay for healthcare. Let the federal government and the state government and the local government take responsibilities for all the hospitals in their area, because what's the most important thing is the people who are going to need these services. We are trying to improve our health outcome. We are trying to improve our life expectancy. So we need to rethink all these things, because a lot of people are dying. Like my senior colleague just mentioned that one of his friends who was 61 years old dropped dead in his room. That could have been from a condition that if there had been surveillance, it would have been caught maybe 2 years ago, and that death would have been prevented. But it is essentially, you need to have money. Like I always try to explain to people, you can think of the human body as a car. If your car is making a certain type of noise and you don't have extra money in your pocket, you will not take it to the mechanic until that car stops working on the road. And that's at that point in time, you are going to spend more, or you are probably not going to be able to even use the car, maybe because the engine knocked or something. So if people's economy can be better, they can, spend money on surveillance, on prevention. Prevention is always cheaper in healthcare than cure. If we spend money on our environmental, redesigning and all of that, we can control malaria. If we control malaria, we lift a whole lot of burden off of the health sector. Because malaria, this is the strategy that has always been used before the advent of chloroquine. When the Americans wanted to build the Panama Canal, and everybody was dying of malaria. All they did was to do a drainage that took the water away from where they were working, and they were able to complete that canal. So we can do environmental restructuring, which is also a part of healthcare funding that will bring down the cost, the burden of malaria. And then we can free up our doctors to do more important things that will save lives and extend our life expectancy. Because the truth is that it concerns all of us. Everybody is going to get old. Everybody is going to be nursing something. A lot of people nurse something, things, conditions that they don't know, and then it takes them away, suddenly. Two popular, actors in Hollywood just died, I think, this last week. It is very sad. And that is the trend in Nigeria. Eternally, you see a lot of all these popular people. As it is affecting them, it's affecting the people too. That is why we have a 70% youth population in Nigeria, because a lot of the older ones have died. I'm actually, at this point, I'm scared of calling my father to ask about his friends, because I don't want to hear the bad news, because that is the story that I've always been hearing, So the new administration needs to go back to the drawing board and change the structure and give it something that is sustainable, not something that everybody keeps coming to the federal government every 2 years or 3 years or 6 months to ask for something and then go on strike. No, we need to make them comfortable, but we need to restructure, because this system will not work. This system is built to work against itself.
Okay. All right. Now, this, if I have to hinge it on that, let's talk about the issue of healthcare financing, because that is, it seemed to be one of the major challenges in health, or in the health sector, where there is no funding, so everything is collapsing and all of that. Now, the resident doctors are asking for 200% increase. Let's assume that the 200% is even given to them. In the next few years, because of the realities of economic this and that 200% will not mean anything. So it takes us back to the same cycle where there's still going to be complaints again of this is not available, that is not available, our monies are not enough, inflation rate has risen, and all of that. Talk to us from the window of healthcare financing in such a way that there's a sustainable, formula that will keep healthcare going in such a way we don't have to come back to these issues of strikes again.
He mentioned that the doctor in the U.S. mentioned some of the critical area. First, you have to have a linkage of the health to the economy, to the whole economy. It's not just like health existing and in silos, and we're talking about economic differently, because both of them should actually be linked. And then, of course, health insurance has been one of the low-hanging fruits. Enrolled a lot of people in the health insurance. Of course, with high unemployment rate, you're going to see low enrollment. You must be able to define ways of you know, at the community level, at the local level, at even other business endeavors, you know, people selling things, people to contribute. But the critical thing to make health insurance work is trust. You know, people just feel that you put money, give money to people, the money is eaten. So, and that is drawing a lot of people back. So we have to really assure that trust and demonstrate that the money actually does what we say it's going to do. So that is the second critical aspect is this, is that we have to really encourage health entrepreneurs. You see other professions, they'll be able to move money from even outside other sources to their profession to grow the profession. We see, for instance, if you look at the accounting profession, you've seen a lot of companies coming from abroad, joining, you know, and forming mergers with accounting, with engineering firms to lift the performance of that engineering firm beyond what is possible in Nigeria. We're not seeing that in health. Okay, but
why not?
Because, you know, because the laws could be a lot of constraints. For instance, if you're thinking about chain distribution of pharmaceutical products in Nigeria now, and you are coming to Nigeria to purchase pharmacy from another country, they won't allow you until you go through some really sticky processes. And then the same thing in health. You know, you cannot just say, okay, I'm coming from, say, Mayo Clinic, I'm coming from Mount Sinai, or even from one of the hospitals, you know, in Europe, and so I'm coming to set up, you know, another branch of the hospital in Nigeria to engage a lot of people and do most of those perform some of those operations. But in reality, you can't do that because of the law that is guiding it. And we need that. We need a law that will free that space. We need a law that will encourage local entrepreneurs. We need a law that will encourage inflow of money and special consideration, you know, and free the business space for health intervention to come in. We need that. You know, so we can't. Our health, our health insurance will not do much for now. It won't do much.
Can you hear me?
All right. This is where we'll have to wrap things up now. We must thank you, Dr. T. May Bawandu, as well as Dr. Marindoti Oludare for your time on the program. Thank you, gentlemen.
Thank you.
Thank you.